Anergy panel. Have any of you ever been asked to do an anergy panel? Okay, that's very unhappy. Makes me unhappy. Anergy panels have been dead for like 10 years, literally. They don't work. They don't tell you anything. They don't help with the diagnosis. If you have a positive anergy panel but a negative skin test, it doesn't mean that the skin test is really negative. So don't use anergy panels. So if they give you that option, it's not the right answer. And then TB treatment is 4 drugs. That's right. And it's always at weight-based dosing, except that almost invariably people max out at a dose and they get a standard dosing. Again, you don't need to know the doses, but you do need to know side effects. So isoniazid is the I in mud piles, so it can give you an anion gap. It's hepatotoxic, as are most of the TB treatment medications. Rifampin, it ramps up the metabolism of other drugs, so it can drop levels of OCPs, it can drop levels of antiarrhythmics, so it can be quite problematic. It also turns all your body fluids orange, which can be alarming to people. They think they're having hematuria when it's actually orange. It'll stain contact lenses. Ethambutol gives you optic neuritis, so you can cause people to have transient color blindness by treating them for TB. And pyrazinamide is extraordinarily nausea-inducing and hepatotoxic. For actual pulmonary TB, which is only the one that you need to know anything about, it's 6 months of DOT. Extrapulmonary TB you don't need to worry about. So the 3 endemic geographic fungi, histo is in the Mississippi-Ohio River Valley. Coxy is desert southwest, which we actually see a fair amount of with immigrants coming here to work in the agricultural industry here. And then crypto is not necessarily a geographic fungus. I put it on here. The other one that is geographic that pertains to us is blastomyces. Histo gives you a whole bunch of things, most often interstitial pneumonia with ulcers. It can give you mucocutaneous presentation. It gives you marrow suppression. That's one thing to know for the boards. And then fibrosing mediastinitis, which is the kind of entity that's most closely associated with histoplasmosis. The lesion is a coin lesion, so either pathologically or on chest radiography is a coin lesion. That's the buzzword. Coxy, you get hilar nodes. It's associated with enodosum, so often coxy can be mistaken for a primary presentation of sarcoid. And the other thing with coxy is that it gives you cavities in the lungs, but classically they have a very thin wall. So if a radiologist tells you that it's a thin-walled cavity, it may point you towards coxy as being a responsible bug. And then crypto, realize all of these are inhaled. So crypto, even though we think about it as being a CNS bug, people can get cryptococcus of the lungs. You can have primary cryptopneumonitis. Usually it's subclinical, but sometimes people will present, especially if they get a big snootful of crypto, they'll develop a clinical pneumonitis. And it's really important for steroid recipients, irrespective of HIVers, but people that are on high-dose steroids for any reason. Crypto is an entity that can cause meningitis in those people, and then transplant folks. Almost uniformly, they'll need an LP. Okay. Questions about respiratory kinds of things? Okay. Norovirus. This is very kind of fair game for the boards because of how frequent it's being encountered now, especially in nursing homes. So the characteristic is this really explosive outbreaks within congregate facilities. So cruise ships, nursing homes, hospitals, daycare facilities. And it can be the kids or anybody who's in there. It's extraordinarily infectious. You need a very, very low inoculum, little in the order of, I think, like 5 to 10 organisms or virions before you're infected. Highly transmissible by fomites or fecal-oral transmission. The things that you'll see in the stem of the question will be in a nursing home thing is that the patients are almost all presenting with vomiting before cramping, then they get febrile. So the vomiting, then cramping, then fever, and then onset of watery diarrhea is like a norovirus thing. A lot of people, a surprising number of people develop constitutional symptoms as well. I don't know how closely it relates with your age, but it seems to sort of fit a bit that people get just in general sicker the older you are. And it can be really profoundly dehydrating. So these people can get acute renal failure from norovirus and die, especially if they're trying to be managed at the nursing home without appropriate laboratory stuff. Treatment is oral rehydration. There's no antiviral therapy for noro. And you can, unlike with C. diff, you can use antimotility agents to help with norovirus. It's okay, because it's not a toxin-mediated process like C. diff. Ripped from the headlines now, dysentery is bloody stools. In the U.S., there are 4 causes, of which O157H7 is the top of the list. The variant that's in Europe now and is coming over here is different than O157H7, but it's still a Shiga toxin-producing E. coli. The important thing with any of the Shiga toxin-producing E. coli is they can cause hemolytic uremic syndrome. Shigella is number 2 on the list, and Shigella gave its toxin to the Shiga toxin-producing E. coli, so it produces much of the same picture as O157H7. CAMPI is poultry or unpasteurized milk. The association here is Guillain-Barré syndrome, so you have somebody with an ascending flaccid paralysis after consuming poultry or unpasteurized milk products. That's, you should think, Campylobacter. So stool culture would be the first test that you would order. Non-typhoid salmonella. There was an outbreak several years ago, and the boards, they love weird stuff. So pet reptiles. So if you have a kid with a turtle or an iguana, it's salmonella. It's non-typhi. And treatment, again, as is in the news, this E. coli you don't treat with antibiotics. And the rationale is that it's kind of like Jarisch-Herxheimer, when you treat syphilis and all the bugs die at once and they dump their guts and then you get this big inflammatory response and people feel like hell. It's the same idea here, that you lyse all the bugs at once and the toxin's built up and then you dump it in the system, you get a megadose of toxin and then you wind up in renal failure. I'm not sure that actually relates in clinical practice, but still all the recommendations are to not treat bloody diarrhea in the U.S. If it's been isolated and found out to be E. coli related. Shigella or salmonella, you can use a quinolone safely. And then for people that are traveling overseas, these are the ones that you get more often, actually. So azithromycin, pill in the pocket, you give them a prescription before they leave. So it's azithromycin is the appropriate antibiotic. And then CAMPI is azithrom, quinolone. C. diff, you should know the C. diff sort of dose escalation bit. So for an initial episode of mild to moderate disease, it's okay to use Flagyl. Flagyl is not technically approved for treating C. diff, but we use it all the time because it works. The only approved treatment for C. diff as of 3-4 months ago was oral vancomycin. Now there's a new agent which we have yet to sort of implement in clinical practice. But if you have an initial episode that's severe, and they'll give you some criteria. They'll tell you they have a white count. They'll tell you they're an early renal failure, or that they have some other kind of complicating medical issue. Then vanc first. Don't do Flagyl first. So this is a very reasonable question for the medicine boards now. And if they're severe and they've got shock or megacolon, it's still oral vanc plus Flagyl. So you do both. If they have an ileus, intrarectal vanc, so that is a real treatment and it does work when they can't tolerate anything or they have a complete blockage. First recurrence, do the same thing that you did the first time. If they have a second recurrence, it's a vancomycin taper, so it's actually over 6 weeks. The 6-week period is a vanc taper for C. diff. This actually should probably have a star on it, an info star. Just, age is less than 200, CD4, it's also, there's a different definition of percentage if it's less than 14%, or if you have any age-defining illness at any CD4 count. Testing, ELISA testing is very highly sensitive, and the reason is that it's better to have false positives than to miss a true positive. So it throws a wide net, catches people, and then the Western is highly specific. This is sort of borderline-y for medicine boards, but you can get false positive testing on a Western related to medical disease. So especially thyroid disease, lupus, pregnancy can give you enough antibodies that will cross-react and give you at least an indeterminate Western. And then the next step for testing would be what? Viral. Acute retroviral, again, looks like a mono-like illness. It will give you a rash it can look very much like a syphilis rash. You can get mucocutaneous ulcers, so it's referred to sometimes as a chancre, an HIV chancre, although it's not appropriate to call it that. You can get sore throat. It just looks exactly like mono, basically. And again, meningitis. Diagnosis is by RNA. So if you have a patient that you're suspecting of acute HIV, serologies will be negative, so don't bother with them. Go with an RNA. And for a while, the boards was throwing P24 antigen on there, and that's an antiquated test. In some editions of the MixSAP, it still says P24. It's the wrong answer. It's RNA. So don't go with P24. This is starred because you definitely for sure need to know what levels need prophylaxis and what don't. If you're above 200, don't do anything. You don't need to give them anything, nothing special. If they're below 200, you need to prophylax for pneumocystis and toxo. The order of preference is Bactrim first. If they're sulfa-allergic, then you go with Dapsone. If they can't take Dapsone for some reason, it's atovaquone or Mepron. This is, I think, at least no Bactrim is first line. Pentamidine only covers pneumocystis. So if the person has allergies or intolerance of the other ones, and you do pentamidine, you're only covering pneumocystis. They can still get toxo. Thrush. This question comes up a lot. If they have thrush, you treat it and then you stop. You don't keep them on prophylaxis for thrush. It's not required. But realize that if it's just oral candidiasis, that's one thing. If they have esophageal candidiasis, you need full treatment. It's usually IV treatment for that. When your CD4 count falls below 50, it's MAC prophylaxis with azithromycin once weekly. That would be also fair game for the boards.
Can I ask you a question?
Yeah.
So what if their CD4 count greater than 200, but they've had an asymptomatic illness?
Yeah. The boards won't do that to you.
Okay.
The issue does come up though, and it's a very important point actually that the CD4 200 is at the top of the bell curve. So people got thrush at lower counts and at higher counts. It's the same with all the OIs. So it's a range. If I see somebody in the hospital that has a CD4 of 250 and I'm suspecting pneumocystis, I don't say, oh, well, it's over 200, they don't have pneumocystis. I get the DFA anyway. So the proper answer would probably be if the person had a history of thrush, which is a proxy for pneumocystis, actually, that they travel together so often at the same CD4 thresholds, that you should think about if a person has a CD4 count of 350 and they present with thrush, they should probably get pneumocystis prophylaxis. That's really an ID fellow boards question, though. But thanks for asking. ARVs, this is a work in progress, as it has been since 1996. The real answer is that if you're below 200, everybody gets treated, period. The question really is whether or not to treat during OI. So the conventional wisdom before 2 years ago was wait until after they've recovered and then start ARVs. There was a clinical trial that was done that proved definitively that for certain OIs, starting ARVs during or early after the diagnosis of the OI improved mortality. It's unclear to me if that's actually going to make it onto the boards because it is relatively new, and I don't think that it is clinical practice, but it's not widely sort of publicized yet. And there's still the OIs were like pneumocystis. Pneumocystis was like the overwhelming OI in there. It breaks down for crypto or for TB meningitis or for tuberculous disease of the lung or extrapulmonary TB, because it's unclear if you have a closed compartment, if you get iris, if the person could hemorrhage and die or herniate and die. So that's where things sort of break down. I think that for